today I'm understanding the reason why you people are sitting in the back, because the AC is there. Those in front cannot get the AC, benefits of the AC. Agree, but those at the back, please pay attention. Last bench, please pay attention. Okay. Now, today we're going to talk about another point I want to tell you, all of you, is that you have how many months for your university exams? How many months do you have for your university exams? 2 months. How many of you all have attendance shortage? Quite a few. So you have to make up the attendance shortage in the next 2 months. Otherwise, as per the university rules, you will not be allowed to write the exam. Okay. So please pay attention. Please attend all the classes. Okay. So with that, let me start with today's program, today's class regarding diabetes. Now, you all know what diabetes is, but nevertheless, I am taking you through the key points. So diabetes is a chronic metabolic disorder in which the body can't metabolize carbohydrates, fats and proteins because of defects in insulin secretion or action. So classification of diabetes also you are aware. Type 1, type 2. Type 1 is what? What is type 1? What is type 1 diabetes? What is type 1 diabetes? What is type 1 diabetes? Basically, beta cell destruction. Insulin is not being produced. Type 2 is the other one, which is insulin resistance with insulin secretory deficiency. And there are other types, but these are the two main types, type 1 and type 2. Type 1 requires insulin. Type 2 doesn't require insulin. It comes in later stages in life. Okay. So you have also genetic defects in beta cell function, insulin action, exocrine pancreas disease, drug-induced endocrinopathies, infections, other rare forms, and gestational diabetes, diabetes during pregnancy. Quite often we see that diabetes occurs during pregnancy. In many cases it remains after pregnancy, and in many cases it resolves on its own. So what is diabetes about? It's a multi-layered factor in which you also have what is called the metabolic X syndrome, which includes abdominal obesity, hyperglycemia, hypertension, lipids. So in this is the thing which makes most people prone to sudden deaths, this metabolic X syndrome, a combination of these factors. So when the when the body mass index is more than 25, or when the waist is more than 40 for men and 35 for women, when the fasting blood sugar is more than 110 or on diabetic medicines, and when the patient is taking lipid medication, when triglycerides are more than 150, HDL is below 40, and hypertension, taking medicines for BP. So all these programs can contribute to what is called metabolic syndrome, metabolic X syndrome, which results in deaths, can result in deaths below the age of 50, 60 and all. So you find a number of younger age group people, they are suffering from this thing, so-called metabolic X syndrome. So, going to the epidemiology of, this is an old slide. Diabetes is very, very common in the world. You have so many million cases. By this year, I mean last year it was supposed to go to 300 million cases. Southeast Asia region itself, 30 million cases again, should have become 60 million by this year. And India is considered diabetes capital of the world. So you have a 2.4% rural and 4 to 11%, 6 points urban. So at one point of time, it was thought that diabetes is a disease of the affluent people. Okay, people who are rich, they get diabetes, they get hypertension. But it's no longer the case. Even an ordinary person can get diabetes. So this is again NCDs. If you look at NCDs, non-communicable disease, you find that it's a major cause. Diabetes is 2% only, but lot of diabetes cases are undetected, and diabetes itself causes problems in other things. Okay. So what is the reason for increased industrialization? The reason for increased industrialization is, what is the reason for increased industrialization? What is the reason for increased industrialization? Bolo? What is the reason for increased industrialization? What is the reason for this? What is the reason for increased diabetes? Bolo? Look that side instead of looking at your phone and chatting with somebody. Okay, what's up? So industrialization, socio-economic development, population growth, age structure and urbanization. So, as I told you, it was previously not thought to occur in rural people, but it is now occurring also in urban people. So, if you look at the features, insulin-dependent diabetes mellitus, it occurs below the age of 30 years, and that the host is man, of course, and you have a sedentary lifestyle. Non-insulin diabetes mellitus, it occurs in both sexes. It occurs in older age. So most of us, including you people, some of you may have developed diabetes in older life, maybe when you're 50, 60, whatever. And the environment is that what contributes to that is low dietary fibers, malnutrition, alcohol, stress, and viral infection, beta cell destruction of the pancreas. Okay. And obesity is there. Gestational diabetes or mellitus, these are the causes for non-insulin dependent diabetes. So diabetes, insulin dependent and non-insulin dependent. These are two things which are very basic. So the clinical features of diabetes. Do you remember any of the clinical features? Anybody? Any clinical features of diabetes? Huh? Huh? Excessive urination, very good. What else? Anybody else? Increasing thirst, okay, very good. Increasing thirst, increasing urination. Okay. You often find people, when they go to, particularly elderly people, when they go to sleep, they wake up to pass urine. That's a sign of, that's usually a sign of, symptom of diabetes. Okay. So classical diabetes symptoms you should not miss. First one is, as your friend said, frequent urination. Second one is unexplained weight loss. Third one is increased thirst. This is also what somebody said. Excessive fatigue. Fourth one is both weight gain and weight loss are symptoms, mind you. Weight gain and weight loss are both there. Slow healing of any ulcers, excessive sleep, and blurred vision. So, these are the things which are there. These are warning signs of diabetes that one should not miss. So, if you look at this picture of related to the body, you have polydipsia, polyphagia, that is increased thirst, increased appetite, lethargy, stupor, that is then you have weight loss, you have respiratory problems like Kussmaul's breathing, hyperventilation, which occurs usually in, hyperventilation occurs usually in what? Diabetic ketoacidosis. Then you have smell of acetone, you have nausea, vomiting, abdominal pain, and also you have polyuria and glycosuria. So during our time, the examiner would ask, any case, any medicine or surgical case or whatever, arki karan hote pare. So we used to get fumble. So our seniors used to say, if the examiner keeps asking you, what is the other reason? Say some other cause. Say diabetes. Because diabetes can cause everything except pregnancy. That is true thing. Diabetes can cause everything except pregnancy. So diabetes is the cause of many things, as you can see from this chart. So again, what are complications of diabetes? Once again, it affects all parts of the body, not just the blood sugar. It affects the eyes, it affects the nerves, it affects the heart, it affects the foot, it can cause neuropathy, it can cause stroke. So in other words, diabetes is something which is often neglected. Why it is neglected? We give medicines for blood sugar, but we never tell the patients about these possible complications. Most common complication we see is, what is the most common complication we see? Common complication for which the patient comes. Look at this and tell me which is the common complication for which the patient comes to you. You started your clinics, right? देखे जो तो सर्जिकल वार्ड में कॉमन कॉम्प्लिकेशन এটা দেখা যাচ্ছে কি বলো tingling and numbness is one, more important than that, diabetic foot or diabetic ulcer. Okay, that's a very common thing. tingling and numbness can be due to other causes also, but diabetic foot is quite common. So if you go to the wards, you will find mostly in surgical ward, 1 or 2 cases of diabetic ulcer. Diagnose it, you do a fasting blood sugar, it should be less than 110. Then you do a oral glucose tolerance test, which is you give 75 grams of glucose, and you measure the blood sugar after 2 hours. If it is below then it should be below 140. Then third one is RBS, random blood sugar. Okay, anytime, whatever it is. So you have something called pre-diabetes and diabetes. So pre-diabetes, the diabetes range should be between 110 to 125, and the fasting and pre-diabetes IGT should be 140 to 199. Okay, in the oral glucose tolerance test. So these are just terms, pre-diabetes, diabetes, but it's always good to remember the real diabetes. Now there's another term which is important, which is glycosylated hemoglobin. This gives you an idea whether the diabetes is under control or not. HbA1c, normal is less than 5.7. If it's more than 6.5, it means the diabetes cannot be controlled by this alone. So you'll need more drugs perhaps, and he's going to be a tough person to control. So you look at the HbA1c also, it should be ideally below 5.7, pre-diabetic 5.7 to 6.4, diabetic 6.5. Nowadays a lot of people just come, they show you your blood sugar, they could say our blood sugar report. Blood sugar report is shudu HbA1c dekha. But that is not the thing. You should have a HbA1c along with the fasting and the postprandial. So it should be below 5.7, the HbA1c. Now let us look at type 1 or type 2. Type 1 diabetes, age is below 25 years, abrupt onset of severe symptoms like polyuria, polydipsia, ketosis, he is ketosis prone, may develop ketosis spontaneously, is dependent on insulin to sustain life. He cannot live without insulin. So insulin nite hi hobe. And has a BMI of less than 18.5. So if these conditions are not fulfilled, he is likely to have diabetes, type 2 diabetes. Okay. Provided there is no other cause like steroid use, acromegaly, etc. So investigations during follow-up, you do a urine blood sugar, ECG once a year, urine albumin, urea, creatinine, retinoscopy, and glycosylated hemoglobin once in 3 to 6 months. These are the common investigations that you do in a case of diabetes. Okay. So management, the first thing in management is the diet, lifestyle modifications, oral hypoglycemic agents, and insulin. So why is the diet management required? To control the weight, obviously, to have the complete nutritional requirements. Nowadays, we have a lot of people doing fasting, intermittent fasting, this diet, Atkins diet, that diet, keto diet, carbo diet, and all this stuff. But this is just basic diet management to control weight, to complete nutritional requirements, to maintain blood glucose level in normal limits, to correct any associated blood lipid abnormalities. So if you look at the diabetes food pyramid, the maximum should be green vegetables, green grains, beans and starchy vegetables. Then you should have 2 to 4 servings of fruits, vegetables. Then you can have meat. Nowhere it is said that you cannot have fish or meat for diabetes. Milk 2 to 3 servings, but at the top, a minimum should be fats, sweets and alcohol. Fats, sweets and alcohol should be the ones that should be absolutely avoided. So at the bottom level, maximum you should take vegetables, beans and grains, followed by fruits, vegetables, meat, milk. But alcohol and fats and sweets should be avoided. So at top of the pyramid. Okay. Again, when you talk about diet, you have the diet should also give you calories. You can't just cut down the food. So 55% from carbohydrates, 30% from fat, and 15% from protein. Okay. So again, here there is a slight calculation in as far as overweight, normal weight, etc. is concerned. Normal weight you need 20 kilocalories per kg, 30 kilocalories, overweight 20 kilocalories, and you get little more 35 for heavy worker, and underweight 40 kilocalories for underweight. Okay. So avoid sweets, avoid overeating, avoid fasting, avoid alcohol. Okay. These are things that should be done. 4 to 5 small frequent meals, and almonds to lower cholesterol levels. Take apple, guava, and avoid excessive salt. These are things which are there. Okay. What should you avoid? What should you avoid while in a diabetic diet? Bolo? What should you avoid in a diabetic diet? What should you avoid in a diabetic diet? Huh? What should you avoid in a diabetic diet? Just look in front of you, you'll get the answer. Look in front of you. Look in front of you, you'll get the answer instead of looking at the book and chatting with your friends. Huh? Key? What will you avoid? Avoid excess salt. Likhte bacho na? Likhte bacho ki bacho na? Bacho. Okay. So please pay attention. So 4 to 5 small frequent meals, almonds to lower cholesterol, and take apple and guava and avoid excessive salt. This is very important. Exercise. Regular exercise, walking, half an hour, that's brisk walking, maintains the weight, stop smoking, foot care. Oral diabetic drugs, sulfonylureas, biguanides, so that pharmacology should. So you must have studied this in pharmacology. Alpha glucosidase inhibitors like acarbose, then rosiglitazone, pioglitazone, more newer drugs have come. So this is the mechanism of the oral anti-hypoglycemic drugs. This I won't go into it much because I think you have studied this in pharmacology, no? Yes or no? Podicho? Yes or no? Yes. So I just go through the names of drugs. Metformin is the commonest one. Then you have glimepiride, glipizide. The relatively new ones are ripaglinide, pioglitazone, and acarbose. Okay. So they have different modes of action. Tumra eta pharmacology podicho, I'm not going into the details of that. Okay. So sometimes you need a combination of drugs. And then you have insulin, where oral hypoglycemic agents are not enough. You have insulin. Insulin is given basically for type 1 diabetes as well as for people on type 2 who cannot sustain on just oral hypoglycemic agents. So you have different types of insulin: soluble insulin, rapid acting insulin, prolonged acting insulin. Okay. So this includes Lispro, Aspart, NPH, zinc insulin, Glargine. Okay. These are prolonged acting insulins. Now this is important test. Technique of injection: painless, 30G or 31G needles. It is given subcutaneously. It can be given in the thigh, the usual part, abdomen and arms. Now this is one thing in which the patient is trained to do a subcutaneous injection. Patient ke train kara hoche how to give subcutaneous injection, either in the abdomen or in the thigh or in the arms. So the patient is trained for it. Okay. Subcutaneous, 30 minutes for onset of action, about 1 hour, 1.5 hours for peak action, should be given before meals. Start with a small dose and increase as needed. Complications of insulin therapy are obviously sudden hypoglycemia, lipohypertrophy, injection site abscess, insulin resistance, insulin antibodies, weight gain, and in overdose, insulin stimulates hunger. So insulin is something which you have to adjust the dose, titrate the dose. Beshi dile khoti, kam dile khoti. So how do you prevent it? Population strategy is primary. You have a population strategy as well as a high-risk strategy. So what is the population strategy? Is primordial prevention, basically weight reduction, exercise, modification of diet. High-risk strategies avoid diabetogenic drugs. Now, there's a tendency among all medical people, all doctors, particularly young generation or old generation, whatever you like to call it, to use steroids. What is the advantage of steroids? What is the advantage, potential advantage of steroids? Bolo? What is the advantage of steroids? Potential advantage. What is the, have you studied pharmacology? Podicho ki podo? Podicho. Okay, stick bullet effect. So you give steroids, so everything will become okay. But the problem is that steroids, if once it's not stopped properly, it can lead to diabetes. So steroid is a drug which is, if you go to the villages, they're giving steroids left, right and center. Visalon 10 mg twice daily for 2 weeks and other things. But once you stop the steroids, blood sugar goes up. Similarly, for any such thing which causes steroids, you have. So that is very important. Reduce the factors causing atherosclerosis, like smoking, hypertension and cholesterol. So this is a Indian risk factor score, Indian diabetic risk factor. Age below 35 years, score is 0. That means your chance of getting diabetes is less. I suppose all of you are in that group. 35 to 49, score is 20. More than 50 is 30. Then you have your waist circumference is another factor. If it's more than 90 centimeters among females or 100 centimeters males, the score becomes 20. Physical activity, if there's mild exercise only, the score becomes 20 again. Vigorous exercise, the score becomes 0. Family history of diabetes, no history of diabetes in parents, 0. One parent is diabetic, the score is 10. Both parents are diabetic, it is 20. So if there's a family history of diabetes, it's very important that that should be corrected in some way. You have a higher risk. You can't correct the fact that your parents have diabetes, but definitely you can take steps. Like for example, your physical activity, your waist circumference, these are things which can be done. So if it is overall score is more than 60, very high risk of having diabetes, then you do an oral glucose tolerance test, at least otherwise at least random or fasting blood sugar. 30 to 50, risk is moderate, but still you do go for a checkup. If it is below 30, diabetes is very low. So here the biggest things are family history, physical activity, waist circumference and age. Age we cannot modify. As you grow older, your age increases. Family history also you can't do anything about it. But exercise and waist circumference, these are the two things which can be modified to a large extent. Then who are the people who should target? Age over 30 years, yes, definitely. Overweight, body mass index more than 23 kgs. Central obesity, waist hip ratio men more than 9.9. Family history of diabetes, sedentary lifestyle, previously identified impaired fasting blood glucose or impaired glucose tolerance, history of diabetes, mellitus, gestational diabetes, recurrent fetal loss or delivery of large baby, hypertension, dyslipidemia. So these are all asymptomatic people but with these problems. So asymptomatic people with these problems should be screened for diabetes. Okay. Continuing history of gestational diabetes, pregnant women, adults with tuberculosis. Now tuberculosis is another thing which is with along with diabetes, it's a cross thing. Diabetes tells you to lose weight, tuberculosis tells you to increase weight because tuberculosis is a medicine which makes it a wasting disease. Diabetes on the other hand, you put on weight. So it's a cross, dangerous combination. Diabetes and tuberculosis. Patients on diabetic drugs, diabetogenic drugs like steroids, thiazides. Patients with PCOD, what's the new name of PCOD? What's the new name of PCOD? Huh? What is the new name of PCOD? Huh? What? BMOH? What is the thing? So the name has changed now. It was previously PCOD, just about 2 weeks back it changed. Good that you know the name. Change. History of premature vascular disease also there. Secondary prevention is early diagnosis and treatment, maintain blood glucose level, maintain ideal weight, blood pressure instrument, routine blood glucose monitoring, urine for ketones and proteins, and glycosylated hemoglobin estimation. 6 monthly it should be done and should be less than 6%. And again, for diabetics, it's always good to keep sugar in your pocket because suddenly there may be hypoglycemia. Secondly, Western countries, they have some tag saying that this person is diabetic. So here we don't have that facility, but still the person who goes for he should be carrying sugar in his pocket in case he has hypoglycemia. Then the other thing should be weight, blood pressure measurement, visual acuity. Visual acuity is another thing which often is neglected. We often ask the patient's sugar, "Hey, Oshud Khan, thik ho jabe." But we never ask the patient, "Apnar choke kono problem ache." He may say, "Amar choke to test korte gechi." But that choke problem is not necessarily chhani. It can be diabetic retinopathy. Okay. So visual acuity is one factor. Feet care, self-care, adhere to drugs, diet, exercise, investigations, periodic checkup. Recognition of symptoms of hypoglycemia. Identification card with treatment details. This is what I said. Amar sugar ache, but ami ki oshud khache, ami jani, ota chhada keu jane na. So if this person goes somewhere, he should have a card that this medicine is being taken. So either the change of medicines or the medicine is not taken today, or he's taken 2 tablets today, which causes a fall in which causes a fall in sugar. So identification card is essential, which is not there for practical reasons. Now, foot ulceration is a big thing. Okay. So, these are a few factors which increase foot ulceration. First is increasing age, poor diabetic education, vascular disease, ill-fitting shoes, lack of joint mobility, neuropathy, previous foot ulcer, low socioeconomic group, and male sex. So this is very important because if the diabetic foot ulcer is not properly taken care of, it can land up with a lot of problems. What are the problems? They can even be gangrene, leading to loss of the finger or toes, or even amputation of the toes or limb. So foot ulcer is not something to be neglected. Okay. So that has to be controlled not just by dressings and things, but also by diabetic control. So feet care, wash feet daily at home, dry them, inspect and sprinkle talcum powder, ordinary powder. Avoid walking bare feet even at home. Wear soft cotton socks and canvas shoes. Avoid tight-fitting shoes and chappals. Cut nails carefully after bath. See for the sensations. These are often things. The last one, see for the sensations. The patient may not feel that he can feel himself. So he'll say some feeling. Somebody said there, tingling sensation. The tingling sensation occurs here. Okay. So see for the sensations. So wash feet daily. Avoid walking on bare feet. Wear cotton socks. Avoid tight-fitting shoes and chappals. Cut nails after bath. And see for the sensations. Again, do not use hot water bottles or heating pads for heating the feet. Do not sit with your legs crossed. Do not use a pumice stone to remove callousness. You find this under your soles you have something that is called corn. So don't remove that. Use a pumice stone to remove it. Do not use commercial wart or corn removers on your feet. These are all things which should be avoided. Do not perform bathroom surgery by using razor blades or other sharp instruments on your feet. A common tendency that you have a small thing, ami nije korbo. And do not again ignore any minor foot problem. Use cream or lotion that keeps your skin soft and free of cracks. Okay, these are small things but rather important also. Regular self-monitoring, tertiary prevention, disability limitation if there is any disability, and then the diabetes clinic. Basically, just to get back to the two things. One is diabetes can affect any part of the body. You have 2 types of diabetes, type 1 and type 2. And then you have various symptoms of diabetes which should not be ignored. Type 1 and type 2, this is just going through recap. Type 1 is insulin dependent, sedentary lifestyle. Type 2 is, the reason is low dietary fibers, malnutrition, alcohol, stress, viral infections. Clinically, these are the classical things: polyuria, polydipsia, polyphagia, and slow healing, excess sleep, blurred vision, excess fatigue. This is, if you remember this picture, you can get all the major symptoms of diabetes. And these are the complications, which starting with mainly from diabetic foot, glaucoma, cataracts, diabetic retinopathy, peripheral arterial disease, heart attack, stroke, peripheral neuropathy, diabetic nephropathy. And how the common diagnosis is through blood test. Fasting blood sugar should be below 110, postprandial is below 140, and the various other methods. They also have HbA1c, which should be less than 5.7. This is as a marker for diabetes. Okay. Then this is the characteristic of type 1 diabetes. Age below 25 years, abrupt onset of symptoms. Is ketosis prone, dependent on insulin, that's the most important thing. Has a BMI of less than 18.5. And anybody who's got diabetes but doesn't fall in this criteria, he is most likely to have type 2 diabetes. So these are investigations that are done: sugar, fasting blood sugar, ECG, blood urea, creatinine, retinoscopy, glycosylated hemoglobin. Management, you look at diet, lifestyle modifications, OHA, insulin. Diet management, control the weight, maintain nutritional requirements, change in the dietary pattern. Right on top, minimum must be sweets, fat and alcohol. Right at the bottom, you should have green leafy vegetables, starchy vegetables. Then different calorie calculation. Avoid sweets, avoid overeating, avoid fasting, avoid alcohol. And take apple and go, avoid excess salt. Lifestyle modifications, regular walking, stop smoking, maintenance of weight, foot care, oral hypoglycemics, we've already talked about. Insulin, technique of insulin is subcutaneous, abdominal, thigh and arms. Patients are usually taught to give it. So insulin therapy, you start with small dose increase as needed, 30 minutes for onset, 60 to 90 minutes for peak action. Complications, hypoglycemia, injection site abscess, weight gain, and insulin stimulates hunger. So prevention, you have a population strategy which includes primordial prevention, weight maintenance, and diet and exercise. High risk strategy, avoid diabetogenic drugs, reduce the risk factors causing atherosclerosis. So this is the Indian diabetic risk factor score. If the most important here is the ways which can modifiable is physical activity and waist circumference. You cannot modify your family history, you cannot modify your age. So the second and third points are the most important. Then who are the people for targeting for diabetes? Obviously, though, based on the scores, people with overweight, over 30 years, family history of diarrhea, sedentary lifestyle, history of gestational diabetes, hypertension, dyslipidemia. And these are the other things: adults with tuberculosis, people on diabetogenic drugs like steroids, PCD. Secondary prevention, maintain early diagnosis and treatment, maintain weight, blood pressure maintenance, routine blood glucose monitoring, urine for ketones, glycosylated hemoglobin. Secondary prevention, feet care, keep sugar in your pocket, identification card. These are factors regarding foot ulceration, increasing risk of ulceration. This is how you do the feet care. I've told you about this. Wash feet daily, wear cotton socks, avoid tight fitting shoes, cut nails, see for sensations. And these are some other things which for foot care. Regular self-glucose monitoring, tertiary prevention, and diabetes clinic. Look at the Indian scenario. Now, we talked about diabetes is the big thing. We look at the Indian scenario, which is India's got the maximum, the second highest number of diabetic in the world. It's called the diabetic capital. And so you have diagnosis. We talked about this again. Criteria for diagnosis. This we talked. Now this we are talking about the control program of diabetes. Okay. Now this program was started first in 1987. It was called the National Diabetic Control Program. Because of this. Why was it started? Because we found that there were a number of cases of diabetes which were there, and that's why the cases were increased. Okay. So then 1995-96, they said let us increase it to the entire country. So objective was obviously to control prevention of diabetes, early diagnosis and rehabilitation, etc. Then finally from 1997, it became 1997 was the diabetic capital of, what was the program's name in 1997? What is the program's name in 1997? What is the name of the program in 1997? What is the name of the program in 1997? 1997, what was the name of the program for diabetes? 1997, the program in naam tak hi chula. After that, it became National Program for Control of Diabetes, Cardiovascular Disease, Stroke. Before that, what was the name of the program? Before that, it was just National Program for Diabetes Control. Okay. So they've included the other components also. That is cardiovascular disease and stroke also. Okay. This was started in 2008. This includes not only diabetes, it includes cardiovascular disease also. Early detection of diabetes, etc. So the various interventions planned in NPCDCS, you have a health promotion and health education of the community, early detection of cases, strengthening health systems in all levels to tackle NCDs. So these are the components envisaged in the NPCDs. So what is the first thing? First thing is, in the health service, the smallest component is the subcenter. So what does the subcenter have? Can a subcenter detect diabetes? Yes or no? Diabetes, there's only subcenter only health promotion of diabetes, awareness of diabetes, but they refer a suspected case to a higher center. So the subcenter itself is manned by usually by an ASHA worker or Anganwadi worker or an A&M, but they refer the case to the primary health center or the CHC and follow-up of patient put on treatment. Next one is community health center, CHC, or the first referral unit. Okay. So this includes prevention and health promotion, including counseling. Here you have, at the PHC level, you have blood sugar, cholesterol, lipid profile, urea, creatinine, all this is there, and opportunistic screening of diabetes. One of the common things that you will see in camps is, if you go to a camp, you will say, Dr. Baba, pressure take to Degbin. Pressure ache? You measure the pressure is okay. Then he will ask you, sir, amar sugar ache ki na dekhte parben? Then he will ask you, but you don't have the glucometer. People want to know what is the sugar, but you don't have the glucometer. So that is one thing. Then, so at the health center level, you have PHC level, you have diagnostic facilities as well as management of diabetes, and again reference to higher centers. District hospitals, you manage cases including emergency services. Here you blood sugar, lipid profile. Again, complicated cases refer to a higher center. Then in medical colleges, mentoring of district hospitals, early diagnosis and management of diabetes in complicated cases, training of health personnel. That is also done by in a medical college. Okay. So here we are also doing population-based screening. That is, population-based screening is being done under National Program for Control of Diabetes. This would be particularly beneficial to women. Okay. So this is being done at some places. And the next one is the ASHA worker. ASHA worker, they are giving cards, health card. ASHA worker will undertake completion of the card, and each PHC will maintain the health family folder to ensure the population is registered. So any person living in that area will be registered, and the family would be given a unique health card which will help identification of family members. So this is done as part of the population-based screening. So every family has got a card in which the patient's problems are mentioned. Like for example, if he's got diabetes, it is mentioned there. Okay. This also documents health events, screening, treatment, complications, etc. Screening of diabetes it's performed once a year. If it is positive at the village level subcenter, then confirmation of diabetes, mellitus, coronary vascular assessment is done, and in case of complications referred to CHC or district hospital. So and the ASHA worker, what she does is listing of all adults above the age of 30 years, completing the community assessment checklist, organizing a screening day, undertaking health promotion activity, undertaking follow-up, and creating patient support groups. So basically, it is the ASHA worker who is responsible for this in a big way. what she does, lists all patients above age of 30 years, completes the card assessment checkup, organizes screening day for all this, undertakes health promotion activity, undertakes follow-up, and also create patient support groups. So I have got diabetes, somebody else has got a diabetes, so you can sit and chat and see, explain what is your problems, their problems. So creating patient support groups. Okay. So some more new initiatives have come up, like they are saying that NCD app and all, and we have a NCD clinic in various places. So this is the various things which we have achieved. So conclusion is that diabetes is a major metabolic disease. Government started this National Diabetes Control Program, which is now merged with the National Program for Cardiovascular Diseases and Stroke and Cancer. Okay. So I think we'll stop now. Thank you.